Good afternoon, everyone. I'm very happy and honored to co-chair this session with Dr. Nava Levit-Binnun. In this session, we'll have 7 short talks by members of the Israeli Neuropsychoanalytic Forum who will present their research works. We won't take questions between the talks, but afterwards I hope we'll have enough time to open it to discussion. And our first speaker is Dr. Iftah Biran, who is a behavioral neurologist and a psychiatrist working as a psychiatric consultant to the Department of Neurology in Tel Aviv Medical Center. He's also a psychoanalytic candidate at the Max Eitengon Institute of Psychoanalysis. And Iftah will talk about psychodynamic mechanisms in Echolalia.
Okay, thank you, Kobe. Good afternoon. First, a small self-disclosure. When we designed or thought about the program of the conference, I thought that it's going to be a great idea to have like very short talks, and now that I have to do this in 10 minutes, I feel that it wasn't such a good idea. So I'm going to speak about psychodynamic mechanisms in Echolalia. And so I told her, "You are angry at me." It was Mrs. E. She's the last patient for the day. I've been seeing this 60-something years old lady for the past year. Following a severe traumatic brain injury leading to profound left hemispheric damage, her life was shattered. She suffers from right-sided weakness, severe language impairment, and an amotivational, abulic, pseudo-catatonic state. However, at times, she would burst in anger or repeat things directed at her as though she was an echo, hence echolalia. So I tell her, "You are angry at me," but I add a question mark in the end of my comment. "You are angry at me?" The minute I say it, I know it is a dangerous zone, as whenever she is confronted with a comment probing her state of mind, she gets irritated. Nevertheless, the question mark hangs in the air. "You are angry at me." I can hear the rustle of the tam-tam drums. And then she repeats me, at first mockingly, with the same intonation, "You are angry at me." But repetition after repetition, the intonation gets lost, and although the words are pronounced correctly, the meaning also gets lost and can't be grasped anymore, and we are left with a bundle of illegible phonemes. Dr. Bagali, Mrs. E-therapist, Mrs. Rave, and me, the co-authors of this paper, were intrigued in the last few months by Mrs. E tendency to repeat phrases directed at her. She would repeat them for up to 40 times, especially when asked questions directed at her affective state, like what I did, or directed at highly loaded affective personal matters. Echolalia, that is the term for this kind of echo-like language behavior, is encountered in specific kinds of aphasia and language impairments. The dominant neurological understanding of this phenomenon is that echolalia is a disinhibited response to an outside phonemic stimulus that does not pass any modulation or transformation in the mental linguistic apparatus and is introjected and projected without any change. I want to show this notion of echolalia by using Lichtheim's model of aphasia and language impairments. This model was a very prominent model of aphasias in the 19th century and is still dominant in the current neurological thinking. According to this model, linguistic stimuli enter through the auditory sensory receptive area, that is the right side of this, what's called the house of Lichtheim. They are then processed through the transformation down in a conceptual symbolic area, that is what's symboled as B, and then are expressed to the outside world in what hopefully would differ from the original percept. So the auditory, the conceptual, and the motor areas. In echolalia, the conceptual symbolic part is damaged, that is the B on top, or disconnected, and the unmetabolized percept is expressed without change or modulation through this direct loop that you see down in this house of Lichtheim. And this loop is actually usually used for repetition of phrases. According to this analysis, Mrs. E damage will be somewhere in this conceptual area. However, at times, actually most of the time, she would present with a different form of language impairment, resembling Broca's motor aphasia. She would reply coherently, but slowly, very effortfully, and with very, very short phrases. And her comprehension would be intact. This pattern is typical to language impairments secondary to motor aphasias and to the damage to the motor part of the language apparatus, that is what's symboled here in X. Damage that is typified by slow, effortful speech with intact comprehension. I want to emphasize that although I'm talking now in a relatively neurological lingo, I'm not oblivious to the fact that in both modes of this language impairment, Mrs. E seemed miserable and very heroic in her struggle to overcome this cognitive and linguistic deficit. So what causes the switch between these two modes? Probably it is not a change in the structural damage, as Mrs. E fluctuates freely between the two. One could claim that the function of these two putative damaged loci is influenced differentially during stress. The function of the conceptual area, or the B area, is weakened during stress, as when Mrs. E is confronted with anxiety-provoking questions, and the unmodulated receptive stimuli is able to overcome the damage of the motor area and exit as an echo. The claim, or this claim, does not take into account specific psychodynamic mechanisms. Here, we want to elaborate on some dynamic mechanisms that can use this specific constellation of anatomical damage. We claim that the main defense mechanism used by Mrs. E is that of disavowal or complete negation, and that the echolalia is a vehicle for a profound annihilation of meaning. From the scant verbal communication with Mrs. E during her therapy sessions with Dr. Bahagali and during the follow-up visits with me, we know that disavowal is Mrs. E preferred and dominant coping mechanism with stressful stimuli. For example, when looking at this upper TAT card, the Maggie card, she said, somebody is sick and the doctor is treating her, okay? So she doesn't negate or disavow anything. But then immediately after this card, I give her this next card and she says, he's not worried anymore. There is someone else in the picture, triangles. So in just a split of a second, the worrisome content is denied and abolished. How can echolalia serve disavowal and denial? One could argue that in a very concrete manner, when verbal stimuli are not digested, but are rather projected without any mental work and transformation, a never-ending loop of introjection, projection, no meaning can be accessed. This resembles the mythic... 1 minute. Okay, I'm missing one slide, never mind. This resembles the this resembles the Ouroboros, the mythical snake that is eating itself in a never-ending feast of self-consumption. More than that, going back to Lichtheim's model, in the echolalic mode, the conceptual meaning-generating areas are dysfunctional and no meaning can be generated or associated and linked to. Thus, the percept remains meaningless, or actually the percept is stripped from its meaning. Looking again at the you are angry at me exchange, Mrs. E at first repeated the phrase with a stressful, anxiety-provoking question mark. I used myself, but in the following repetitions, the phrases were stripped from any specific intonation as well as meaning. The repetition is actually the tool that is used to attack meaning. When words are repeated time after time, they tend to lose their meaning. This is a semantic satiation effect that was originally described by Severance in 1907 and in its current term by Jones in 1962. When words are repeated time after time, or when words are looked at continuously, like what you have been doing in the last 2 minutes, they lose their meaning and their symbolic function. This is a feeling of the listener of Mrs. E gets from her repetition. Thinking in terms of projective identification, which is highly relevant here, it is probably the experience of Mrs. E. Echolalia, as a defense mechanism, is a drastic measure to confront reality and deny it. In this regard, it is a psychotic defense mechanism. A similar parallel mechanism is described by Freud in his models for psychotic clang associations, where he suggests, similar to the semiotics distinction between the signifier and the signified, that words have two domains. The first is what they convey in the real world, actually the right-sided part. And the second is the words as a physical object, the way they look in written language, they're presented on script, or the way we feel when we pronounce them. These two domains can be dissociated, and this dissociation is the essence of Mrs. E reversal to the endless, meaningless repetitions. Echolalia, repetitions and imitative behavior are not just a pathological defense mechanism. They are also used to learn, convey meaning, and acquire understanding. Writing this paper and reading it now, I find myself repeating things, and I believe that these pseudo-echolalia-like repeats are not just in the service of attacking links and meanings, but rather the opposite. In this regard, understanding the interplay of meaning generation and meaning destruction can further help in understanding Mrs. E. The echolalia is on the one side a tool to annihilate meaning, but on the other side, it is also a communicative vehicle to convey Mrs. E internal state. This empathic understanding of what seemed prima facie to be a meaningless, random, reflex-like clinical phenomenon enable us, and respectively, and especially Dr. Baagali, in treating and helping Mrs. E. Just as a teaser, understanding that the echolalia is anxiety-driven, self-destructive mechanism directed us toward using interpretations that emphasize the continuity, stability, and endurance of the therapeutic situation, addressing the pathological repetitive echolalia with normalized repetitive environment. But this is the scope of another more detailed presentation. Thank you.
So our next speaker is Tali Marron. We changed the order. Tali Marron is a PhD student in the field of neuropsychoanalysis at Bar-Ilan University under the supervision of Professor Miriam Faust and Dr. Iftah Biran. She is also a clinical child psychologist, now in internship at Shelvata Hospital. She has been an active member of the Israeli Forum for Neuropsychoanalysis for 8 years. She will now tell us about part of her innovative research in which she uses fMRI to study dynamic processes in therapy.
Good afternoon. I wanted to invite someone, a volunteer, to join me on stage, but after speaking to Professor Turnbull, he agreed to help me. So would you mind coming up for one moment? Thank you. Yeah, you can stand here. All right. So, Oliver, I'm going to try something with you. I'm going to ask you to focus inward a little bit. I'm going to give you a word. And I want you to tell me the first association that comes to your mind. Okay? Sure. Wait, I'll just finish explaining. After you say the first word, say another word that's in association to the first word you said, and in that manner, in the form of a chain. Okay? So, the word is net.
Net, basket, reticulum, Colosseum, gladiator, death, sand, blood.
Thank you so much. Wow. Thank you so much, Professor Turnbull. He already left the stage very quickly. I just wanted to ask you, how was it for you?
Traumatic.
I'm sorry, we can talk about that later. I'll be happy to help you. But yes, free association is not an easy task. And that's exactly what Professor Turnbull just did. Now, free association is one of the basic tools we have in psychoanalysis and in psychodynamic psychotherapy. Freud, who saw the goal of psychotherapy as uncovering the unconscious, used free association as the main route to do that. Now, in the 1970s, Donald Winnicott, redefined the goal of therapy as being able to live creatively. Now, what does that mean, being able to live creatively? All of us might know the situation when we're stuck on something. We have this thought that we're stuck on, or some kind of behavior that we're stuck on. So being able to live creatively means that you have flexible options for these areas that you're stuck in. For example, a patient of mine always hears feedback from his boss and he perceives it as criticism. Same thing from his wife. But in therapy, he became a little bit more flexible in that area, and he started to have more options. Now, the first thing he thinks when he hears some feedback, it might be criticism, but it also might be other things. And this, of course, makes him happier. He doesn't feel like he's under a magnifying glass all the time. So how do we reach that creativity in therapy? What Winnicott also said is that the way we reach the goal of living creatively is by play. Now, unlike with children, play in adults is through speech. It's through this free association, very similar to what Professor Turnbull just did. So Winnicott actually said that the process of free association is a creative process. The more a person is more free to let out associations with less inhibitions, you are very good, by the way, the more creative that person is, and the more chance he has of living creatively. So I really love Winnicott's theories personally and use them in the clinic. But as I use it, my neuroscientist voice, I hear it inside my head saying, all right, but what does this mean, living creatively? How can I even know that free association is a creative process and that therapy actually does make you more creative? Well, luckily, 40 years after Winnicott, we have advanced brain technologies and much better cognitive definitions of amorphic things such as creativity. So I could actually test that as part of my PhD. So first of all, what is creativity? Creativity right now is defined as being able to come up with something new and original, a combination between things that has an original outcome, but it is also useful and meaningful. And this creative process is built up of mainly two cognitive processes, which are, one, divergent thinking. Divergent thinking means the ability to come up with many different ideas, multiple ideas from different fields, combining different things, like brainstorming. But in order to come out with a creative solution for a problem, we also need convergent thinking, more task-oriented, which means I have to choose from all my crazy ideas one that fits the purpose that I'm looking for. Now, inside this, of course, I'm personally in my research focusing on the divergent part, because free association, as I want to show, and as Winnicott said, is more of a divergent process, the ability to come up with many ideas. It has a few sub-processes, I'll just say them in a word. One ability is to come up with as many ideas as possible, having a high fluency. One is being able to connect remote associations inside your mind into new ideas from different flexible fields. And in the end, coming out with an original creative idea. All right, so this is our cognitive definition of creativity. Soon we'll use it in our research of free association. But what are the brain networks that lie beneath these creative processes? In 2001, in the lab of Marcus Rochelle in Washington, they found a network that is highly relevant and highly researched today. And this network is a kind of network that sits at the base, of our thinking. It's a network that when you're focused on a task, it's deactivated, but when you look inward, think about yourself, think about your future, then it is activated more. So this network is called the default mode network. It's highly activated when we're doing rest, just sitting down thinking. When we mind wander, let's say right now you're focused on me and sometimes your mind might wander to what you're going to do after the lecture. So yeah, your default mode is being activated at those moments. And apparently, the default mode network is also highly relevant for divergent thinking. To come up with many ideas, you have to be focused inward and in this unfocused manner. The default is, these are the main hubs, as you can see. It's made up of medial areas, the medial prefrontal cortex that before Professor Turnbull talked about, the inferior parietal lobe that associates between different kinds of different senses of perception, and the posterior cingulate cortex and precuneus, which have a lot to do about thinking about oneself, one's future, and one's past. All right, so this is the brain network. Now, behaviorally, how can we test divergent thinking? There are many tests for that. One of the most famous ones is the alternative uses task. We ask participants to say as many things they can think of what you can do, for example, with a newspaper. So that's one of the tests. You can try and think about 1, 2 things they can do with a newspaper, try and make them creative. Maybe you got them. All right. So, my research. What we wanted to see is if free association is indeed a sort of creative process. And if the more a person is able to associate freely, if they are more creative, actually. So what we would expect is if I ask someone to free associate, the more far apart the associations are, the more remote they are one from another, and the more associations they're actually able to produce, the higher they will scores they will receive on creativity tests, such as the alternative uses test that I just told you about. And additionally, we expect the brain activations of areas that are suggested and widely thought to be relevant for creative thinking, such as the default mode network, also to rise. So, what we did is we took 36 participants, gave them alternative uses tests and a whole battery of other divergent thinking tests, and then we put them in the scanner. And we asked them there to free associate, very similar to what I did before. So they free associated, and this we compared to other kinds of fluency, such as a semantic fluency, where it's associating, for example, kinds of animals. But it's not a free association. We also compared it to phonological fluency, saying words that begin with a certain letter, and episodic fluency. The participants were asked to remember lists that I taught them before they entered the scanner. All right, so these are all our controls of non-free fluencies that we compared the free association fluency to. After participants left the scanner, we asked 2 judges to judge their free association chains. They judged them for a few things. One was associative flexibility. They saw in the chain how many times they changed themes. They also tested and scored how far each association is from the one previous. All right, so that way we have behavioral scores of these chains. So, what are our results? First of all, free association, in comparison to all of our control groups, activates the default mode network. As you can see, it's the PCC, precuneus, and the right and left IPL were highly activated during this condition. Additionally, we can see over there, there's another area I haven't spoken about, the left inferior frontal gyrus. That's usually an area that's more has to do with executive control. This is actually a replication of a previous research on free association by Spence and colleagues who focused on the frontal areas. But this is a question because this area usually has to do with inhibition. So maybe people were slightly embarrassed and didn't say all of the associations that they wanted to say. This we are still thinking about. So not only did free association in general activate the default mode network, the more associations people gave, And the more flexible their associations were, higher activations inside the default mode network in the PCC, precuneus, and IPL. And behaviorally, the higher scores that people received in terms of amount of associations, the higher scores they received in terms of amount of answers in the alternative uses task. Okay, so whoever's good at giving association could give a lot of answers to what to do with the newspaper. And the more flexible their association chains were, actually predicted how creative their answers on the creativity tests would be. So, what I'm trying to say is that here, free association is indeed a creative process. It can predict if I give someone, I ask someone to free associate, then it can actually give me some kind of idea of his creative abilities. Now, this is really great to find out that it's a creative process, but it doesn't stop here. It's very easy to run this test on subjects. So first of all, if anyone here is interested in doing it in their research or on their patients, they can come and talk to me and we can think about it. But I personally also wanted to know if really psychotherapy can actually make you more creative and make your thinking more flexible. So what I just told you was actually just the beginning of my PhD research. And I'll just tell you in 1 minute, and if you want to hear the rest, you have to come again next year, because I haven't finished analyzing it. But after they free associated in the scanner, half of the participants went to a short simulation of free association therapy. The other half went to some kind of control therapy. And then they went in the scanner again and free associated, and of course, did again creativity tests. And we'll see if indeed our therapy can make their associations more flexible, and if I can also see it behaviorally in their creative, on their creativity tests. All right, so I want to say thank you to the forum that raised me into this project and supported me the whole way, and the amazing group of women that I work with, all my supervisors and help, my husband and my friends and my family. Thank you.
Thank you, Kobe. And our next speaker is Dr. Hadas Mor Ofek. Hadas is a senior clinical psychologist and a supervisor. She teaches psychotherapy and training programs and is involved in research in the trauma field. And she will be speaking to us about a neuropsychoanalytic integration of tongues in dissociation, implications of the Polyvagal Theory of the autonomic nervous system.
Microphone.
2 years ago, I came to visit one of my patients. What did I do? When she was hospitalized in a mental health unit. She was a victim of repeated sexual assaults as a child and suffered from complex PTSD. We're sitting and she was telling me about experiences from the last few days. She was there, talkative, being present. I could feel it. And then suddenly, she was gone. Well, actually, physically, she was sitting there, but there was nobody at home. Her face was frozen. She did not reply. I lost eye contact with her. Well, she was dissociated. As you can imagine, I felt quite helpless. And I would like to talk in the next few minutes about the neuropsychoanalytic perspective on dissociation. As you've heard along the day, neuropsychoanalysis brings together different domains of knowledge, and this enables an integration that have a lot of meanings to the clinical field. Well, dissociation is long-rooted in psychoanalysis tradition. Freud, that was influenced by Breuer and Charcot, was interested in the origins of hysteria. His inquiries led him to introduce the seduction theory, where he connected the hysteric symptoms into traumatic, inappropriate sexual experiences in childhood that elicited the usage of the most primitive defense mechanisms, including dissociation. Past the years, dissociation became a key concept in the trauma field, containing various meanings, including alterations in consciousness. This phenomenon was called detached dissociation. And this is one of the complex PTSD symptoms. And complex PTSD is a syndrome that resulted from prolonged and repeated exposure to interpersonal trauma, often accompanied with inescapable circumstances. The neuropsychoanalytic perspective on dissociation, detached dissociation, is based on the Polyvagal Theory. Okay. The Polyvagal Theory is a revised model of the autonomic nervous system that was introduced by Stephen Porges. This model claims that the autonomic nervous system is a three-parts, phylogenetically hierarchical ordered system containing the parasympathetic part, which is the most evolved part in the system, the sympathetic part, and a third part, which is the most primitive subsystem. As a matter of fact, a reptilian remain in our nervous system, the dorsal-vagal subsystem. This model is different than the classical model that I guess all of us know from physiology in psychological studies. The model that was introduced almost 100 years ago by Walter Cannon that sees the autonomic nervous system as a two-part antagonist system containing the parasympathetic part that regulates the body in secure and safe environment, enable the person to engage in a lot of activities such as learning, social interaction, and it feels quite comfortable and calm to be under parasympathetic regulation. As opposed to the sympathetic regulation under threats that prepares the body for the intensive survival actions or fight and flight. And of course, it feels the tension and anxiety and aggression. But the polyvagal theory recognizes the third part, the reptilian remain. And when that part regulates the body in extreme situation of life danger, inescapable attacks, we will see a reptilian reaction, metabolic depression that will be presented in slowing, very much slowing of heart rate and drops in blood pressure, sensory shutdown, immobilization and disconnection, or we can call it, in a way, detached dissociation. There is a basic principle in the brain functioning, the principle of dissolution, that claims that the higher phylogenetically neural circuits inhibit the lower, more primitive ones. But when the higher circuits are functionless or do not suit the situation, we will see the rise of the more primitive circuits. So under inescapable attacks where escape is not possible, neither fighting back, we will see the dorsal-vagal regulation. This principle of dissolution is based on neuroception. This is a term that Stephen Porges coined. And it means a continuous non-conscious risk evaluation process that supported by sensory and association cortices. For complex and regular PTSD patients, there is a twisted neuroception. So they perceive a lot of neutral situation as inescapable attacks. And this is why they are so often reacting in dissociation. Well, taking this into account in the clinical situation may offer us an opportunity for intervention. We can offer an interpretation that recognizes the inescapable attack elements in the situation that preceded the dissociative episode. By intervening this way, we can especially when the dissociative episode begins, we can stop and prevent the dissociative cascade by interfering in the neuroception process. And I want to go back to the scene I've described earlier, me and my patient. I was sitting there quite helpless. And then I was trying to figure out what kind of inescapable elements were in the situation. Maybe it was in their interaction between us, in the interpersonal area. Maybe I was sitting too close to her and that intimidated her or said something offensive that she could not resist. And then I remembered that she was just telling me that in the evening before, her roommate has had a very graphic, brutal flashback of a rape. It was a terrible trigger to my patient, and she wanted to leave the room, but it was the visitor's hour, and she was afraid that some of them may recognize her. She was a known lady in her community. So she was locked in the room. I told her, "You've just told me you were in an unbearable situation. You could not escape. And I guess you felt really trapped there. And your body is telling this to us right now." Gradually, her face became more clear. And after a few minutes, we could talk about it and elaborate the traumatic episode she has had. I would like to give another clinical example that resembles the connection between dissociation and hysteria in a different way. It was during a session with an incest survivor patient, and she was talking about her mixed emotions towards me, a lot of transference issues, and I was pushing too hard on her to speak more directly about it. She was trying to answer me, but her words were not very communicative. But I've noticed that her left arm was not moving at all. I pointed it out, and she was touching her arm and said, "Wow, she didn't raise it like me. I can't feel it. My arm is being paralyzed." I remembered that this arm was involved in traumatic episode in her childhood where she had to touch her brother's genitals and could not resist him because he was the only soul that cared about her at that days. I told her, "I pushed hard on you to tell me about your feelings, and maybe you could not resist me because you feel you need me so much. I think that maybe your arm reminded us what that reminded you." She was listening to me because she was not completely dissociated, and then felt her arm was tickling, and after not long time, her arm became motion again and not paralyzed. So in those clinical examples, I just wanted to give you the taste. There was a question about it later. The taste of the neuropsychoanalytic perspective into the clinical, the psychotherapeutic field. Those integrations are a way to use our creativity in a way that elaborates our way to intervene and to make a change. Thank you.
Thank you, Hadas. Our next speaker is Dr. Nava Levit-Binnun. She is head of the Sagol Center for Brain and Mind at the Baruch Ivcher School of Psychology, IDC Herzliya, and the founder and director of the Muda Institute for Mindfulness, Science, and Society. And she will talk about searching for brain mechanisms underlying mental health, insights from basic and applied research.
Okay, thank you. So as I said in the beginning of the day, in the Sagol Center at the IDC, we're interested in finding brain mechanisms and that are underlying mental health and resilience. That's the research part, and I'm just going to give you 3 examples if I have time. One is our search for markers of mental health, and 2 examples of how we try to understand better driving forces of mental health. So I don't know if, how much of you are aware, but there's a rising field now in neuroscience that's called network neuroscience, where a lot of data coming from neuroscience is being analyzed with graph theory and other network analysis tools. And one of the interesting things that is coming out that from many types of data is that it looks like the brain is a complex network, and it's belonging to a subset of complex networks which are called small world networks, which are characterized by several hubs that are connecting many, many points. So most of the points are connected only to a few friends, but then there's a few central points that are enabling a situation that from each point in the network to each point of the network you can actually get in a few steps, and that's called a small world network. And it looks like the brain is actually organized in something that looks like a small world network. And this kind of organization is very, it makes sense that the brain would choose such an organization because it enables on one hand segregation, so different parts of the brain are in charge of different functions, but also integration, fast energy transfer between areas. And what is very interesting is that almost all the pathologies, both psychiatric and neurological, that has been tested in these kind of ways, deviate from small world network structure. And that means, the one way to interpret it is that it means that these networks are less efficient and they're also less robust, because the small world networks are relatively very robust networks. And we thought that maybe if we want to say something on a very deep level, what is the difference between healthy and not healthy, or resilient and non-resilient, vulnerable, maybe that if a network is less resilient or less resilient, then if we perturb it, then it will have different kind of responses, and it would maybe suggest that if we take a person with a network that deviates from this optimal network, and we perturb him or her again and again and again, we'll see some internal intra-subject variability, a greater variability, internal variability inside the person. So this is what we did. Our first group was healthy people, neurotypical people, and people with schizophrenia, and we brought them in, put the EEG cap on their head, and stimulated them with TMS. So you have a TMS coil on their head. This TMS, for those who don't know, is a way to stimulate a local focal area of the brain. It's usually the cortex, at least in this kind of coils. And then there's the sham condition, which feels the same, but it's actually not stimulating. So each person came in, and we tested them on 3 different days, each time 100 repeats. And as you know, we can construct evoked potentials, and I'm sure you heard about evoked potentials. Evoked potentials, an average of 100 repeats, we assume that should characterize the person. So it doesn't matter if it happened on Sunday, Tuesday, or Thursday, we should see the same patterns. Here you can see 3 different days, that's 3 different averages of a patient with schizophrenia versus a control, and already by you can see that there's much more variability here. And just scan with your eyes the reds versus the blues, and you see that the reds are always higher than the blues, and actually each one is an electrode. We had 64 electrodes, and the height is how much variable was the activity across the sessions. And as you can see, the schizophrenia patients are in general much more variable. That means there's a greater internal variability inside them. And this is a simple analysis. We also have more sophisticated analysis. We're just now analyzing the data. But what's interesting is that the pattern overall, that the electrode is similar across the And the people that you can see when the blue is high, the red is high. When the blue is low, the red is low. But it's just a little bit higher. And we think that it is an indication that it's not a certain area, but it's actually something more in the baseline activity, maybe the what we call the spontaneous activity of the brain, which is much more variable. So this is one approach that we're going through, and this is the data. This is a work in progress. Okay, so that was trying to find markers for health. Now I want to show you two projects that are more trying to understand processes that we know, from the clinic or from other situations that are supposed to be beneficial. So we know that, or at least I think you guys know that there's something very strong in a dyadic interaction. Dyadic interaction when two people, the interpersonal space, the interpersonal interaction could be very, very strong and can drive forces of health and rehabilitation and recovery. But it's very difficult to study the dyadic processes in a laboratory and physiologically. But we still try to take upon this challenge upon ourselves, and this is one of the first works we published, where we said, let's begin with just looking at what I call the mere presence. What is the physiological effect of the mere of another person sitting next to you? So the trick was this. We put pairs of people into a room. So here's one pair and another pair. And they saw a movie that was very emotional, which could drive autonomic signals that are indication of emotional arousal. So we measure the autonomic activity of these people. We measure heart rate, we measure skin conductance. And we look at the dynamic signal, which is something very unique to our lab, that we look at dynamic signals and not only on averages. And then the trick was like this. We looked how much synchronous were the physiological signals between pairs that sat in the same room as compared to people that didn't sit together. So everybody saw the same movie, they were in presence of a person, but this person was together with this person in the same room, and this person was not together in the same room. And it's a little bit complicated computation, but the point is that if we look at all the distribution of all possible synchronies, correlations between all the signals, between all the pairs, then we get some kind of a distribution. And the people that were together in the same room actually were always, or on average, were more correlated to each other above and beyond the correlation that is induced by the movie and by the arousal that a person is next to you. So it suggests that another person sitting inside a room with you, a mere presence of another person, can induce another idiosyncratic activation, which is specific to the pair, to the person that sits near you. And we found that the more people were closer in their physiology, they were also closer in their feelings, what they rated according to the movie. So they rated the movie and their feelings in the movie, and the more they were synchronous, they were more closer to their rating. This is really hot from the oven, so you know that when things, usually people don't show it, but I just think that it's so cool, you have to see it. And I hope that the results stay after we finish all the analysis, but we wanted to see what is the effect of attunement on the interpersonal space, and we were more courageous this time, and this time people sat in front of each other, and one person was a discloser. He was telling a personal, intimate, painful story to a listener. And the listener was a person with many hours of meditative practice. So we assume that these people have the ability to be more attuned and more compassionate. This is an assumption, of course. We rated the feelings, first of all. So you can see that the listeners, the long-term meditators, were higher in hope, warmth, lower in sadness, stress, and higher in care when they rated how they felt to the story, the disclosures, which I think is more interesting, were higher in hope, warmth, lower in sadness and stress. That's what they felt after they told the story. And physiologically, we see that the listeners had higher corrugator activity. That's we're measuring the muscle activity here, which is indication of negative emotions. So it looks like they were really reacting to the strong negative story, but they were low on the heart rate, so they weren't stressed when they were listening. And the disclosures were higher in the zygomatic, which is the muscle here, which is correlated with positive emotions. So they were telling a negative disclosing story, but they were feeling better, and that was interesting. And the synchrony between the pairs was higher for the pairs that had a long-term practitioner. I have to say that this is a pilot study, and we're now gathering more dyads. So I hope that, but it's nice that already things pass significance, which is not one thing to say, which may be interesting for you. One of the problems with long-term meditators that some of them are also therapists. So now we can't dissociate the therapist. So we'll have to find either just take therapists or find meditators that are not therapists. This is work with my partner, Yulia Golan, Dr. Yulia Golan, and she's leading this. How much time do I have? Do I have? Okay. So the last thing is that, as you know, we have a mindfulness center, and we're trying to understand the mechanisms underlying mindfulness. And one of the interesting things that are coming out, you heard about James Gross earlier, and one of the things that is coming out now is that the thing that is very, very important for well-being and mental health is your ability to move flexibly between different emotional regulation strategies. So you can have engaging strategies like reappraisal and disengaging strategies like distraction, and your ability to move between distracting and engaging strategies is what is important for your mental health. This is like the hottest thing now in the emotional regulation field. And we thought, wait, this is actually what we're training in mindfulness practice, because we're training our attention to engage and disengage and move flexibly in a emotional context. And we're becoming more and more sensitive to our bodily signals. And maybe this is one of the things that are happening. And indeed, after 8 weeks of a mindfulness-based stress reduction course, students that passed the course, compared to controls that were waiting to start the course, actually became more flexible in moving between engaging and disengaging. So the more you have a slope, the more you're flexible. And now we're doing it with physiology, and we're really trying to see if it's correlated to how you become more sensitive to your internal signals. And this is moving your ability to adapt to choose in an adaptive way between strategies. So thank you for listening. This is my current staff and Yulia, and here's the information that you can get about what we're doing. Thank you.
Thank you, Nava. Our next speaker is Michelle Spector. Michelle holds an MA degree in expressive therapy and is a multidisciplinary researcher with expertise in movement analysis and dance movement therapy. Michelle was granted a New Researcher Award in 2015 by the journal Body, Movement and Dance in Psychotherapy for her study of tweens and coping with crisis using emotorics. Michelle's study presents a new view of understanding human individuality and explains why early parental envelope experiences shape the child's emotional and physical potentials, allowing to anticipate future abilities of the self to cope with crisis. Michelle.
Good afternoon. This conference talking about language would not be complete if we wouldn't introduce the language of our body. And early parental envelope was coined by our dear friend, teacher, and member of our association, Yona Shachar Levy, who is here with us today. Thank you, Yona. You can raise your hand. Apparently, our early experiences are noted in our body movement, even in early ages, but more so as we grow, and these can be foreseen in any way we move about, or sit, or talk. So early parental envelope experiences shape also the child's emotional and physical potentials, allowing to predict their abilities to cope with crisis. This is based on a study of twins coping with crisis using emotorics. You can read about it in the International Journal of Body Movement and Dance and Psychotherapy. It's available online. You have here the link. For those who are not familiar with emotorics, or known today as epimotorics, it's a psychomotor model for the observation, notation, analysis, and interpretation of emotive body and movement in self-environment relations. Yona distinguished between two settings. The parental envelope settings, which is the point zero. From here we develop our movement abilities in all spheres, whether it's motion, emotional, mental, and so forth. And the second is the vertical face-to-face setting, P1. We use for the notation binary charts, which have here, the inner circle represents the poles of the parental envelope setting, whereas the outer circle represents the face-to-face setting. Virtual nurture is a mystery. Human behavior and essence is full of wonders, and there's lots to learn, as you've heard here in this conference. There were many studies, researches going on, and there's still more to explore. I personally believe that epimotorics inside, such as Intel inside, is still out there to help us understand more. So no two are alike. Even identical twins sharing the same genes, growing up in the same environment, end up with very different personalities. And one of the ways to distinguish these personalities is how do they cope with crises. Crisis is something that is important for our development. As parents, we would like to eliminate the struggles and challenges that our kids face on a day-to-day basis. But clearly, it's very important for their capabilities to live a whole, full life. So we distinguish the crisis as something in three main factors, based on our personality, of course. Secondly, how severe or significant the event is for the self. Because for one, a teacher yelling at us in class is no big deal. For others, it can be a tremendous crisis. And third is that the support system. When I started my investigation with twins, it actually started with the first grade crisis. I had 7 kids, out of which 6 were twins, one of a twin. So I was wondering, where is the other twin? How come some of them were identical twins? How come just one is coming to therapy? What's going on with the other one? So I started observing twins, and this actually made me curious, and I started my research with different crises. And to my surprise, it all shows, in a very schematic way, we can see it, that one twin has less presence of the parental envelope setting, whereas more on the face-to-face setting. You can see it in all these 4 examples. One twin, whereas the other twin has more in the P0 and less in the P1 potentials. This consistent distinction led me to understand that there is failures within the parental envelope among twins, I'm speaking here, and dominance forceful prototype in the face-to-face setting of the one twin among the peer, whereas the other one has inappropriate, sorry. Where is that? Age-appropriate presence of P0 potentials and less of the P1. This led me, based on questionnaires and more observations and personality tests, to the distinction between the twins, TT1, twin type 2, which seems more mature, more capable, more outgoing, more social than the other twin. It's all in comparison. And the second twin, which seems more childish, but has actually emotional capabilities, outstanding capabilities to go through crisis. If to summarize this, such as a tree with strong roots laughs at the storm, a heartful parental envelope allows better endurance in crisis. Thank you.
Okay, we opened with Iftah, and now we'll have him once again, Dr. Iftah Biran. And now he will talk about a downward spatial bodily motor bias in conversion disorder, psychomotor, and attentional psycholinguistic perspectives. Iftah.
Okay, so our world, and not just the world of the little prince, is governed by gravitational forces. Therefore, no wonder that the vertical up-down axis is prominent in our daily life, both in our physical environment and in our linguistic behavior. Special metaphors are profound in the way we talk, we speak, we understand things. For example, we say, his mood is elevated, he's deteriorating, thumbs down, thumbs up, and etc. And we have a question here. Are these metaphors just a linguistic phenomenon, or do they teach us something about our inherent body and mental functioning? Are they just an artifact of language, or are they really embodied in our body? So Johnson and Lakoff, in their influential book, Metaphors We Live By, suggest that metaphors are not just a linguistic figure of speech, but that they are rather conceptual. They coined the term conceptual metaphors, and in this regard, they mean that metaphors are inherent to the concept that they refer to and are crucial to its very basic characteristics. In their book, they give special consideration to special metaphors, including the up-down metaphor, and relate them to both cultural factors and physical experiences. And in this regard, they follow, or rather lead, the concept of cognitive embodiment. In this talk, we want to look at this issue and bring evidence to this concept in conversion disorders. Conversion disorders, or functional neurological disorders, or hysteria, if we follow the classic term, are characterized by a neurological deficit which is not really explained good by current day neurological logic. And some researchers argue that researchers and thinkers argue that the hysteria is actually a manifestation of malfunctioning psychodynamic mechanisms, and I'm going to talk about it later. So we wanted to address this issue looking at two lines of evidence. One is based on a study done with Dr. Sivan Gazit as part of her MD thesis in Tel Aviv University. And this was done in collaboration with the big team from the Academic College of Tel Aviv-Yafo, including Dr. Odelia Elkana, Liraz Davidovich, an MA student, and Mrs. Liel Ishayahu, an undergraduate student. And this was an empirical study where we documented a downward attentional bias in patients with conversion disorder. The second line of evidence that we bring is based on Yona's model, the motorics, and this is, in our thinking, a psychodynamic, motivated, naturalistic observation study on bodily symptoms, and it was done, again, with the guidance and the collaboration of Yona, and we used her method. And in this study, we were able to demonstrate that subjects with conversion disorders are usually divert to regress to the early developmental motor patterns that Michelle was talking about, the P0 position, thus placing the bodily distortion in these patients in the context of both psychological and psychical development. Okay, so going back to the first study, here actually we followed the classic psychodynamic theory of hysteria, and I'm going to be very simplistic here. Maybe it's going to insult some of the psychodynamic people. And this notion, we think, or we take the assumption that the psychological stress leads to or is converted to body symptoms and is manifested in body parts. And this actually, psychological distress, is a conflictual libidinal energy. Conflictual means bad, negative, and if following our metaphoric thinking, or maybe more than that, so we would expect that this conflictual libidinal energy would mean a downward bias, and therefore we believe that if this line of thinking is relevant, like attaching the conflictual psychological mechanism with a downward negative bias, then the body would be regarded as belonging to the lower part, or bodily parts will be linked to the lower part of this vertical axis. What we did and how we examined that, we recruited a lot of control patients, a lot of control subjects, and we analyzed for this study 42, and we recruited the conversion disorder patients from the Department of Neurology where I work as a consultant, and it took us, like in 3 months, we were able to recruit to the study around 8 subjects. And what we did, we compared their performance on a very simple task. Subjects were asked to respond as fast as they could to a target, and the target was the round circle that appeared either on the upper part of the screen or on the lower part. And the target was preceded by a keyword. The keyword was either bodily related, like an arm, or non-unbodily related, like photo. And we expected that patients with the conversion disorder to be faster in detecting the lower targets, like the right bottom circle, following a bodily related cue. So this is like the results are significant, and here is the measure of the attentional bias. Positive means that the patients are slower. It takes them more time to detect the upper stimuli, and negative, it takes them less time to detect the upper stimuli. As you can see, a positive bias means that it takes them more time to detect the upper stimuli. As you can see, patients are faster in detecting the lower stimuli, especially following bodily related words. Okay, so this is the first study, and this observation demonstrated an attentional linguistic related vertical bias. But can we further claim that this bias is embodied or that it is related to the body and physical world? So now going to the second study with Yona, and this was actually now in press in Journal of Bodywork and Movement Therapies. What we did here, we actually observed using Yona's paradigm, and especially looking at the distinction between the P0 and P1. P0 in this context would be vertical, opposing the downward gravitational tendency. Sorry, P1 would be opposing the gravitational tendency, while P0 would be more horizontal, unable to cope with the gravitational bias. Okay, so we predicted that patients with conversion disorder would be more in the P0 position or state. And okay, so this is the binary notation that Michelle was talking about. And we recruited 6 patients. This was from a conversion disorder clinic, and this is one of the patients. As you can see, he's walking in a stooped, curved gait. And what you can see here is that all the patients, the 6 patients, really tended to be in the P0 state. I brought the I brought this clip of the patient to demonstrate this observation, and more than that, our thoughts and this studies, both studies are looking at group effect, and you might argue with me or tell me that in this group effect we are missing something of the individual, and we know that conversion disorders and the bodily symptoms convey meaning within them. But I think that although we are looking at a clinical group effect, this helps us to look at further dynamic issues of the specific patient, because every P0 is different in its way. And for example, this patient used to regard himself, in Hebrew it goes very nice, as tzavitzav, a turtleish turtle. Okay, so, and we were thinking about this, the meaning of this, why he calls himself a turtle, and he would really look like a defeated ninja turtle. He would go like that, and we were thinking about the meaning of that for him, and you can go with that and actually in therapeutic sessions with him, like the thinking was like that this P0, for him, the P0 position was meaning creation of a false parental envelope. And to conclude, these 2 studies suggest that patients with conversion disorder demonstrate vertical downward spatial bias. And this bias is spatial, bodily, and motor. And this bias is manifested both overtly in motor and spatial behavior, and covertly in attentional bias. And we propose that these vertical biases are related to gravitational forces, and that this might be reminiscence of early developmental memories. And going back to the Little Prince, as you see, there are many ways to cope with gravitational forces. Thank you.
So, Irit, we have some time. Can we open up for questions? Yeah? Okay, so we have time. If someone wants to ask any of the speakers or raise a discussion, this is a good time now. Okay, so it look, yeah, Yona, כן. רגע, תדברי בה, שישמעו אותך, כמו שצריך.
הערה אחת קטנה. free association ועל בריאות. בעברית יש לנו קשר לשוני בין בריאות והיבראות. אני חושבת שזה התהליך שאת מדברת עליו.
So anyone, yeah.
Did you try to see any imaging or something more neurologically related that would reflect something that happens in conversion disorder?
I mean, all these patients passed a thorough neurological evaluation. I'm also a neurologist, so I mean, we did imaging, like for example, for the patient that I demonstrated his clip, he passed like an extensive neurological workup. His current therapist is here, I think, or is he still here? I saw him before. And he's like, we did a thorough evaluation. For none of them we found anything. I mean, this is conversion disorder, after all.
No, I was thinking along the fMRI kind of idea.
No, we didn't do any fMRI studies, but we did like extensive basic workup. Of course, we know that there are like fMRI findings in conversion disorders like frontal or TPJ, but we didn't look at that.
If to continue, Iftach, did anyone do like network studies on these people? Yeah, yeah, and didn't see anything.
There are a lot of network studies, like in psychogenic seizures. This is like a network in psychogenic pseudo-epileptic seizures. This is like we know that there is a disactivation of epileptic networks. Actually, I presented a case a year ago where the psychogenic seizures, or actually the epileptic network of the patient, the temporal lobe epilepsy, a patient with epilepsy, temporal lobe epilepsy, and his network resembled the network that we see in psychogenic seizures. So we see all these things, especially in epilepsy or psychogenic seizures.
Any other questions?
About complex PTSD and fibromyalgia, if those who work with it can say something about alternative treatment, because not everybody can have this special treatment that you were talking here. So they'll be very happy to know about it, to apply it for a patient of mine in such a position.
So I can talk about multidisciplinary therapy for different disorders or syndromes that involve bodily symptoms that is done in Levinstein Rehabilitation Center, where I work, in the day center there, which involves physical therapists and psychotherapists and occupational therapists who give like a whole an answer to all the different facets, the different sides of the problem, and try together to help the patient get a better life, better functioning. So this is one that I know.
This reminds me that Shai Efrati asked me to say that he's opening a study with children or people that have all kinds of learning difficulties, and there was a history of falling on the head, which made the parents or the therapist may not be relating between the two, but he has some pilot study that this may be related, and if anybody knows, then Shai Efrati is looking for participants.
Hannah, I also want to refer to your question because some of the body-based psychotherapists are a good answer to fibromyalgia and disorders like that. What? Therapists work with the somatic experiences such as Yona Levy and Sylvia.
Okay. So other questions to the speakers or the presentations? Who qualifies for the hyperbaric?
So, as I said, it's multidisciplinary work, and I joined them only for writing a perspective on the paper, so you should really ask them. Shai Efrati is the head of this center, and you should talk to him, okay? I'm sorry, I can't answer this.
I just wanted to comment that a lot was spoken today about emotion, many insights and interesting remarks. I learned a lot. I just want to make a remark. The emotion has in it motion. Nothing was spoken except for the tool about motion in life. And movement and emotive movement, etc. And I think we have to bring this to the fore. Thank you.